So good morning all. Myself, Dr. Manuel Thomas. I am the scientific chairperson. I think we'll give another 2 minutes time. So for some more participants to join in. So after 2 minutes, we'll start with the program. So good morning all.
Thank you, Doctor.
Myself, Dr. Manuel Thomas. I am the scientific chairperson. I think we'll So once more, good morning, everyone. So we'll start with the event. So I would initially I would like to thank everyone for being here. So to invite everyone, to welcome everyone, I would request Dr. Balendra to start with the welcome address.
Balen, sir, we connect to hear you.
Dr. Balendra. I think some network issue. He'll join us soon. So before we start, I just want to tell everyone that this is supposed to be our January webinar. Every month, fourth Sunday, we have a webinar, which is a program by ISPRP. It's an online platform where a multidisciplinary talk is organized, and after the talk, we discuss on it. So those questions, if you have any questions, if time permits, we will take a few questions and at the end of the session. So any queries you have from participant side, please put in the chat box. And if time permits, the moderator will pose the questions to our speaker. So any questions, please put it in the chat box.
Am I audible now?
Yeah, Balendra, we can hear you. Yes, you're audible now. Yes.
So welcome to this. Yeah, sorry for technical glitch. Welcome to the Sunday morning of this ISPRP monthly webinar. And Indian Society of Prostho Restorative and Periodontics is actually an interdisciplinary society where we try to amalgamate all the different branches to actually improve the oral health. And I would like to welcome the speaker of today's, Dr. Vivek Joski, and he will speak on digital smile design. Kindly change the slide, please. Yeah. This is one of the prime area of ISPRP for annual essay competition. And this year we are again coming with a very good topic on annual essay competition, and the topics are actually mentioned here, and it is open for all the UG students PG student, faculty, and private practitioner. There are separate topic for each category, and you can apply. And formal date of announcement will be this year, February 15, and yeah, and the last date of submission is 15th of April. And I also would like to tell you that all the office bearer of ISPRP give a discounted registration in 2024 conference. And all the award winner will have to be physically present there and submit I encourage all of them to submit the essay. And if you have any query, you can just write an email to you, and formal announcement of the ISPRP essay competition will be on February 15. Thank you. Dr. Manuel, over to you.
So thank you so much, Balendra, for this. So this is regarding our ISPRP annual essay competition. So now I would like to welcome the moderator for today's session, who is Mohan, Dr. Mohan. He is currently working as an associate professor in the Department of Periodontics and Implantology at Vishnu Dental College, Bhimavaram at Andhra Pradesh, India. He received his bachelor's degree in 2004 in A.B. Shetty Institute of Dental Sciences, Mangalore. Then master's, he continued to masters in periodontics at CKS Teja Institute of Dental Sciences and Research. His focus of interest is on research issues like e-learning methods in dentistry, proprioceptive derivation concept in dentistry and dental ergonomics, upgrading clinical care skills among undergraduate students. He has published widely in international journals and has over 80 articles and 2 books to his academic credit. So welcome to our moderator, Dr. Mohan Kumar. Now I request Dr. Mohan Kumar to give a brief introduction of our speaker, Dr. Vivek.
Thank you, Dr. Manuel, for inviting me to the ISPRP webinar. Good morning, everyone. It's my pleasure and honor to introduce today's speaker, Dr. Vivek Choske, who has completed his graduation in 1999 and post-graduation in 2005 in the specialty of prosthodontics from Government Dental College, Indore. He worked in Modern Dental College and Research Center as professor and postgraduate guide for 19 years. And now he is presently working as Dean Professor HOD at Dr. H.S. RSM Dental College and Hospital, Hingoli, Maharashtra, since 3.5 years. He had a private practice in Indore and was practicing specialty since last 18 years. He is fellow of Perry Forchard Academy. He also member of British Society of Prosthodontics. He was past secretary, past president, Indian Dental Association, Indore branch. He is the author for various international and national publications. He has co-conducted prestigious Gurukul pre-conference courses at 13th, 18th, and 21st prosthodontics postgraduate conferences, and he is a keynote speaker at various IPS conferences. He was key opinion leader for 3M ESPE and also conducted CDE at local and national level. Dr. Vivek Choske is world accredited dental GPS mentor of GPS functional digital smile design India-wide. He got training from Germany for ExoCAD and is certified trainer for ExoCAD India-wide. Presently, he is section editor in Journal of Indian Prosthodontic Society. He is an EC member and Indian Prosthodontic Society for 7 years. Now, I request Dr. Vivek Choske to start up with the presentation on digital smile designing. The platform is yours, sir.
Thank you very much, sir. I would like to share my screen.
Yes, Dr. Vivek, I have stopped sharing, so you can start with your live sharing.
Is my screen visible?
Yes, your screen is visible, sir.
So welcome all on this Sunday morning. I would like to thank ISPRP, especially Dr. N. Gopi Chandra, the president, Dr. Vibha Shetty, the secretary, and Dr. Manuel Thomas, scientific chairman. And especially thanks to Dr. Manuel, he has been diligently following me for this course. And thanks once again, because this is supposed to be the first webinar of ISPRP for this year. So I am really proud and happy to present the concept of digital smile design to the ISPRPNs and all the members, those who are joining from all over India and abroad. So friend, let me put a disclaimer that I might be discussing some of the digital smile design softwares here. And I am not promoting any of those, and individual discretion is needed. And I have no bond at this juncture with any of these software companies. So before jumping on to the digital smile design, it is very important for us to understand the basic principles of smile design. So as we say that it is a digital smile design, so was there something which was analog smile design or a manual smile design? So let us understand that how we land up to the digital smile design softwares. So friends, what is smile design? So basically there are many scientific and artistic principles which are thrown in the aesthetic world, and when they are considered together can constitute a beautiful smile. So smile designing is not a part of only prostho, but it is an interdisciplinary approach, and it is involving prosthodontics, restorative, orthodontics, and periodontal approach to give a perfect smile design. So smile design or any other treatment starts with the patient interview. As we usually say that one has to meet the mind of the patient before meeting the mouth of the patient. So it is very important to know what are the perception of dentofacial appearance of the patient, what motivation is the patient does the patient need for taking the treatment, what are his realistic are the expectation of the patients, and what does the patient expect out of this aesthetic treatment? Is it realistic or it is non-achievable? So we have to be very sure about this before we see the mouth of the patient. And when we come to the clinical examination, definitely we have to do the comprehensive aesthetic analysis. And the best way is to have the patient standing in the natural head position, where the Frankfurt horizontal plane is parallel to the floor. And we should take the photographs while maintaining the head in the natural head position. And we can mark all these soft tissue landmarks for the assessment of the facial aesthetics. So when we go for a comprehensive aesthetic analysis, this analysis can be divided into facial analysis, labial analysis, dentolabial analysis, and dental analysis. When going for the facial analysis, the first thing which we should go for is the lateral or the profile analysis. As we can see that facial profile can be convex, that is a class 2 skeletal, or can be a concave, that is class 3 skeletal, or prognathism. We can also observe about the paranasal hollowing or flatness, which is the sign of anteroposterior maxillary deficiency. We can, as we can see here, that in the class 3 profile, what we have to see whether it is maxillary retrusion or mandibular protrusion, which is happening, and the treatment thereafter we have to see. Sometimes there is a soft tissue thickness which is present on the chin, which is giving an idea of a class 3 profile, whereas it is just the soft tissue thickness which is anterior to the bony chin, and which can be corrected accordingly. We can see the nasolabial angle. The nasolabial angle, which is around 85 to 120 degree. We can go for labiomental angle, which is around 110 to 130 degree. This labiomental angle can be acute if the lower chin or the lower facial height is reduced or small, or if the lower incisors are proclined. Then coming to the frontal analysis, uh, definitely there are many theories which are given, and there are various facts which are available throughout the aesthetic world. That few of those are that the biozygomatic width, the facial width is 70% of the total facial height. So the biozygomatic width is 70% of the total facial height. So we can check whether the face height is in accordance with the biozygomatic facial width or not. Then we can see the bitemporal width is 80 to 85% of the biozygomatic width, and the bigonial width is 70 to 75% of the biozygomatic width. Then there are two spatial features which play a major role in the smile design. The first is the interpupillary line, and the second is the lip line, as we say, or can intercommissural line, as it is popularly known as, whether it is parallel to the interpupillary line or not, or whether it is perpendicular to the midline of the face. It is usually said that a face can be equally divided into three parts. The vertical facial third should be approximately equal to each other, and we will see about this in the future slides. So a full face can be divided into the three equal parts, from the upper hairline to the glabella, then from glabella to the base of the nose, and from the base of the nose to the chin. And again, the lower one third can be further divided into two parts. First is the one third till the upper lip, and the lower two third comprises of the lower lip and the chin. Then going to the more further into the frontal analysis, we can observe the increased anterior lower facial height, which can be due to vertical maxillary axis, and it can be treated by superior repositioning of the maxilla, anterior segmental impaction of the maxilla, or orthodontic intrusion of the maxillary incisors. We can also observe about the anterior lower facial height increased, which can be due to the increased vertical chin length, and which can be treated through vertical reduction genioplasty. When we observe the face vertically, again, it is said that a face can be divided to the width of 5 eyes. So a face can be divided. We can check the width of the eye, and into 5 times should be the width of the face, and the width of the nose should be equal to the distance between the two eyes. As you can see, the width of the nose is equal to the width of between the two eyes, and the width of the mouth should be equal to the distance of the pupil, as you can clearly see. So they can be correlated to each other. And why it is important to observe that, it is said that when the face is in such proportion, the face looks or the smile looks beautiful. We should go see for the facial bilateral facial symmetry. So marking the midline, we can observe the facial symmetry, and once we can mark the facial midline, we can also mark the occlusal plane and the interpupillary line. And we can observe whether there is a presence of cant or not. As you can see from this image, that from the interpupillary line, if we are comparing it with the intercommissular line, we can very well observe the cant of the occlusion, and which is very pronounced in this image. Also, we can see that the second image is a constructed composite image in which the right side of the face is duplicated on the left side as well. And how does the face looks, and what difference it makes to the overall look of the face. So going for the horizontal lines of reference, there are bipupillary line which is going through the pupil of the eyes. Then there is ophtheriac line, which is going through the eyebrows. Then there is interalar line. Okay, interalar line. Then it is commissural line, which goes through the corner of the mouth. And the vertical line of the reference is the midfacial or the skeletal midline. The vertical line of the reference enables the visual orientation of the midline of the face relative in relation to the midline of the dentition. And we can see the mediolateral discrepancies of the dental midline, right and left side symmetry can be seen from this facial midline. Then what changes from the vertical standpoint would be necessary to obtain the aesthetic results of the smile? As we can see, the disharmony between the incisal edges and the commissural reference lines. So these all horizontal lines and midlines are important reference lines from which we can draw conclusions very easily. As you can see here, we can see the parallelism of the incisal edge to the gingival margin. And in the other photo, we can also see the parallelism of the incisal edge to the gingival margin and to the interpupillary line. Here, dental midline refers to the vertical contact interface between the two maxillary central incisors. But many a times, even this line is canted. Then we should, how do we find the dental midline? We should go with the philtrum of the mouth to see the facial midline and the dental midline then. So here you can see that the facial dental midline is not matching, is not going in between the two central incisors. And it happens in 72% of the cases that the maxillary dental midline does not matches the midline between the central incisors. Usually, mandibular dental midline is assessed in relation to the midpoint of the chin. So, as I have told you that in around 75% of the cases, the maxillary and mandibular midline do not coincide with each other. And it is not as advisable to use mandibular midline as a reference point because it is always and maximum time the maxillary teeth which are in the visible zone while smiling. Also, we should look for the buccal corridors, which we will be looking more in the coming slides. Then we should see for the palatal angulation of the maxillary posterior teeth, whether there is increased palatal root torque or whether the expansion of the posterior maxillary dentition is required. We have to see that. Then we have to see the retroposition maxilla, whether the maxillary advancement is required or not. Then coming to the labial analysis, the after the facial analysis, then the analysis of the lips are important, and in that we will be seeing the lip lines, lip morphology, and lip posture. So as far as lip lines are concerned, where there is a maxillary incisor exposure at rest of 2 to 4 millimeters, but it usually differs according to the age. As the age progresses, there might be complete complete absence of visibility of the incisors. So the visibility of the incisor is important determinant in the smile creation because it serves as a reference point to decide the proper tooth proportion and the gingival levels. So how much of tooth displays there, it is very important. So at rest, usually 2 millimeters of the incisal edge and about 2 millimeter of the gingival show is seen while smiling. Sorry. So according to the gingival display, there can be a high lip line, a medium lip line, and the low lip line. Whereas in the high lip line, we are able to see the major portion of the tooth along with more than 2 to 4 millimeter of the gingiva. Whereas in the medium lip line, we are able to see the 75 to 80% of the tooth with 2 millimeters of gingiva. And whereas in the low lip line, we are not able to see the gingival display. Coming to the lip morphology, lips can be everted, which can be due to the protruded or proclined maxillary incisor teeth, and it can be a flat or backward sloping of the lips, which can give an aged appearance to the facial profile. If the lips are full and not thin, then even the protrusion of the teeth does not matter much. But if the lips are thin, then they might look flattened with incisor retraction. The vermilion show of the lower lip should be slightly more than the upper lip, that is by 2 to 3 millimeters. Coming to the lip posture, when the lips are held together at rest, those are known as the competent lips. And usually we come along the incompetence of the lips, usually in the patients which are having maxillary protrusion. Coming to the dentolabial analysis, uh, the relation of the upper lip to the maxillary incisors. So it can be divided into lip length, smile curtain, and gingival and dental reveal. So what is a smile curtain? It is the increased muscular capacity to raise the upper lip higher than the average on the smiling. And such type of smile is known as gummy smile. So if we come across such gummy smile and if we see that this gummy smile is due to the hypermobility of the upper lip, Botox injection can be one of the solution to improve the smile curtain. Whereas gingival reveal is concerned, a vertically more incisal gingival attachment or any gingival hypertrophy will reduce the incisor exposure. So we have to see that how much of the what should be the height of the incisor, what should be the width of the incisor, and accordingly we should see whether the gingival attachment is at the normal level or whether we are expecting a gingival hypertrophy and how to improve that. Then coming to the dental analysis, we can go for maxillary incisor crown height. What usually is the maxillary incisor crown height throughout the population of a particular region or a particular country. Then what should be the maxillary incisor crown inclination? We have to observe that. And usually it is seen that the maxillary central incisors are approximately 9 to 12 millimeters in length. And the incisal wear usually reduces the incisal exposure. So usually it is seen that when the teeth are incisor are protruding, then the height, the total length of the incisors are reduced. But once the incisors are retroclined, then we can see the increased incisor exposure. So coming to the facial and dental proportions, which we are going to see more in the coming slides. So let us discuss about the different smile lines. The smile line or the smile can be divided into a high smile line, average smile line, and the low smile. So high smile is the one which reveals the total cervicoincisal length of the maxillary anterior teeth and a full band of the gingiva. usually sometime giving notion of gummy smile. And a average smile reveals 75 to 100% of the maxillary teeth with only 2 millimeters of the gingiva, whereas the low smile only displays less than 75% of the maxillary anterior teeth, which with no gingival display. And talking about the different stages of the smile, in the stage 1, the lips are usually closed. In stage 2, there is a resting display of the smile. In stage 3, there is natural smile in which 3/4 of the teeth are seen. And in the stage 4, which is expanded smile, we can see the full length of the teeth with some amount of the gingiva. Sorry. Yeah. So we can also describe the smiles into 5 types depending on their dental and gingival component. Show that type 1 is the maxillary teeth only. Type 2 is the maxillary teeth with 3 millimeter of gingival display. Type 3 mandibular teeth only. Type 4 maxillary and mandibular both teeth are displayed. And in type 5, neither maxillary nor mandibular teeth are displayed. Coming to the contact points, so as we can see from this picture, that the contact points are shifting towards from the incisal edge to the cervical portion as we progress from the incisors to the canine. And we can see that in the incisor region, where the contact area is around 50% of the total contact of the total proximal area of the incisors, and it reduced to 30% as we go from the incisor towards the canine. As we can see, the zenith points. The zenith points are most apical points of the marginal gingival scallops. As we can see in the central incisor, it is slightly distal to the midline. And in the laterals, it is exactly bifurcating the tooth. And in the canines, again, they are slightly distal to the midline of the tooth. So the key points which should be remembered for the stability, comfort, and function, that the anterior teeth must be in harmony with the neutral zone, must be harmony with the lips, with the phonetics, and with the centric relation. And this can be checked by the M position when we ask the patient to say M, and we part the lips gently and should see that around 2 to 4 millimeters of the incisal maxillary edge is being observed. By the E position, in which while saying the patient saying the E, we can have the photographic analysis of this position, and we can see that we can very well appreciate the full length of the teeth. So we have to stick to the certain aesthetic principles if we want to have a real good smile design. So how does the success of the aesthetic treatments depend? It depends on the commitment to the best interest of the patients relative to their oral health. And also, we should also pay the attention to the masticatory system of the patient. And how does the failure happens? Failure happens with our failure to plan about the final outcome of the patient. When we fail to plan for the end, then definitely it will lead to the failure. So failure is not due to the failure of the fracture of the restorations, but it is our failure to acknowledge the certain things like tooth mobility, gingival recession, sensitivity, muscle symptoms, and the breakdown of the temporomandibular joints. So here comes the concept of functional matrix. In any of the aesthetic principles, and to be sure that our final outcome would be a successful, we should stick to these 4 stages of functional matrix, which will ensure the whole aesthetic protocol the stage 1 would comprise of functional aesthetic analysis. The second stage comprise of three-dimensional treatment planning. The third stage comprise of prototype restoration, and the fourth stage comprise of definitive restoration. Let us see one by one. So here, this functional matrix is a sophisticated systems which relates the optimal contours of the anterior teeth to the TMJ and the muscles of mastication. So friends, it is not just only the aesthetic which we have to concentrate upon, but also whether this aesthetics will be functionally successful. We have to pay the whole attention towards the TMJ and the mastication also. And the goal is to provide the predictable solution to our patient with this thing in mind. And then only we can come to best smile design. So whichever material we are using, it should involve all these universal applications. So the first stage is functional aesthetic analysis. Here, it encompasses biological, structural, functional, aesthetic component of the smile. So basically, it is a checklist. We have to one by one, we have to see all the things before proceeding for any type of aesthetic treatment. So the first thing to check is whether the TMJ is healthy or not. TMJ has to be evaluated. If the TMJ is not healthy, then first we have to go for the treatment of the TMJ, and then we have to proceed for the further aesthetic treatment. Then we should go for the 5 requirements of the occlusal stability. What are these 5 requirements of the occlusal stability? How do we check? We have to check whether there are stable stop for all the teeth or the substitutes, whether the anterior guidance is in harmony to the envelope of function, whether the posterior teeth disocclude in protrusion, whether the posterior teeth on the balancing side disocclude during the excursion towards the midline, and whether there is working side interference with the anterior guidance. So when we check all these factors and when we come to a conclusion, then only we should proceed for 6 macro aesthetic goals. So what are these 6 macro aesthetic goals and what are the checklists? We have to check whether the labial embrasures between the central are parallel with the midline and perpendicular to the occlusal plane. If it is not, then we have to include these factors in our aesthetic design. Okay. Then the second, whether the vertical or horizontal edge position of the maxillary central relate to the inner vermilion border of the lower lip. We have to keep this in mind, and we have to make it sure that the vertical and the horizontal edge of the maxillary central incisors fall within the inner vermilion border of the lower lip. Then the third, whether the posterior occlusal plane is in harmony with the incisal plane. So while keeping that in mind, we have to check whether the incisal plane is in harmony with the posterior or the occlusal plane, and both should be parallel to the floor. Then next macro aesthetic is whether the buccal corridor is within the common normal limits. So when we see that there is a narrowing of the maxilla, we can very well see the buccal corridor seems to be very large. So in such cases, we must consider about the expansion of the maxillary arch, or we should consider about how to fill the corner of these smiles. As you can very well see that in the first picture, we can very well appreciate the very large buccal corridor. And when we are going for expansion of the maxilla, we can see that the buccal corridor is reducing. And here we can see that there is no buccal or black corridor present in the smile. Then we should check whether the display of the gingiva is acceptable while smiling. So when the patient is smiling at rest, only 2 to 4 millimeter of the tooth should be revealed. And when there is a posed smile and we are smiling slightly, then the entire maxillary incisors is shown and only 1 to 2 millimeter of the gingiva is seen. Whereas when we ask the patient for spontaneous smile, we should be able to see the whole entire length of the maxillary teeth along with 2 to 4 millimeter of the gingiva. After checking the macro aesthetic goals, we should see the micro aesthetic goals as well. So, does the gingival contour have the proper position and the balance? We should check for that. And how do we check that? Again, we should go see the gingival architecture. Hello? Am I audible? Hello?
Yes, sir, you're audible, sir. Please continue, sir.
Okay. So we should go for the check the gingival architecture, whether there is a symmetry between right side and the left side, whether the zenith points are located where they are supposed to be, and if their symmetry is not there, how to achieve those symmetry, whether the central and the cuspids are at the same height and the zenith is slightly distal to the midline of the tooth, and also the zenith of the lateral should be actually passing through the midline of the tooth and should be identical to the mandibular incisors as well, in which the zenith is at the middle of the gingival contour. Then seeing the gingival height and the position of the tooth, as you can see in this picture, that the height of the central and the cuspids are more apical than the laterals. So this is more aesthetic, and this is what is required when we check the gingival contour or height and position or the gingival architecture in the patient's mouth. As you can very well appreciate in this image, that the height of the central and the cuspid are more apical than the laterals. As in the second picture, you can see that all the heights of the centrals and the laterals are falling in the same line. Even this is acceptable, though it is not ideal, but in aesthetically, it won't look that bad. But if it is this position in which the laterals are more apical to the central and cuspid, such gingival height and position is not acceptable, then we must see the soft tissue contouring of the centrals and the cuspid as well to come to at least the second position which we saw. So second is whether 6 to 11 or all the anteriors are in the golden, M or red proportion. So what, as I told you, we will be talking about the golden proportion. So what is golden proportion? That it is consisting of addition of two previous number to arrive to a next number right to the infinity, like 1 plus 1 is equal to 2. And when we are adding this 2 to 1, we are coming to 3, 3 plus 2 coming to 5, 5 plus 3 coming to 8. And such series is known as golden proportion series. And the ratio of the last two digits is coming to be 1.618. So this proportion is said to be a golden proportion. So when we apply this golden proportion to the teeth, as we can see in the lower picture, that the width of the central incisor is 1.618 times bigger than the lateral. Lateral is 1.618 times bigger than the canine when seen from the front. Okay, so this proportion is said to be, these teeth are said to be in golden proportion. So there are certain rulers which come, which are known as golden ruler, which can tell us what should be the proportion of the teeth when we apply this golden ruler to check the width of the central incisors and the adjacent teeth thereafter. But actually, when it was seen that does golden proportion fits well to the intraoral scenario as well, so it was found that if the golden proportion goes beyond the central incisors, then there is constriction of arch if we apply
the golden proportion to the further teeth, apart from the central incisors. So golden proportion does not work well with other teeth other than the upper central incisors. So there were certain other proportions which were proposed. Those were the M proportion given by method. Sorry. So these M proportion depends on the width of the central incisors, the inter teeth distance, and the number of teeth. So width of the central incisors, the inter teeth distance, and the number of teeth. That is, number of teeth is 6. So depending on these three, they are coming to a proportion which comes usually if the width of the central incisor is taken to be 8, then it comes to be 1.37 in comparison to the 1.618 of the golden proportion. As you can see in this photo, that golden proportion is being applied to the teeth through computer. We can see there is a constriction of arch if we apply the golden proportion to the teeth further than central incisors. It will end up to the constriction of the maxillary arch. So here comes the M proportion, where only other factors which differs from the patient to patient, and for each individual patient there will be a different M proportion, and which would look good in for every individual case. So it is 1.37 if the width of the central incisor is 8 millimeter, in comparison to the golden proportion, which is 1.618. So as you can see in this computer program, that 1.367 proportion seems to be much appropriate than 1.618 golden proportion. Then there was one other proportion which was proposed, which was red proportion, that is recurring aesthetic dental proportion, which is nothing but the proportion of previous tooth with the adjacent tooth, like the proportion of central with lateral, lateral with canine, canine with premolar. So such proportion is known as recurring aesthetic dental proportion. If we see, we can see that the golden proportion only holds good with the total width of 2 central incisors in comparison to the length of the central incisor. So if we check, we can see that it is 1.618 to 1. Okay, the width of both central incisor to the length of the central incisor, which comes around to be 81%. So usually it is said that the ideal proportion of the upper central incisor should be between 75 to 82%. Then the next concept is the papillary position acceptable without the black triangle present? So there are different indices through which we can measure the black triangles and see whether the aesthetic can be achieved without the black triangles. If the black triangles are present, how much width of the black triangles are present, and how to correct those black triangles. Then we should go for the inclination of the anterior teeth, whether it is acceptable or not, and we should see whether they are parallel to each other and parallel to the midline while going from the midline to the posterior teeth. So we should also check for the incisal embrasures, which is the depth of the incisal embrasure is appropriate for the patient. As we can see that as we progress from the central incisors to the posterior teeth, the width of the and the depth of the embrasures increases from 20% to 30% to 50% as we go towards the premolars. So after seeing the macro analysis, micro analysis, then we come to the 3-dimensional treatment planning, which is actually the dental blueprint of the which we are going to achieve. And this can be achieved through diagnostic mounted models. Okay, so mounted models are a must for diagnostic purposes, for a 3D treatment planning, and there should be a second set of the models which should be reference points for all the time which we can revisit and see from where we started and what we want to achieve. So the second set of this cast should be subjected to reductive recontouring or additive waxing, whatever is needed for to simulate the anticipated results. And once this is achieved, it becomes the dental blueprint. So there should be the indices available with the dentist, which should be supplied by the labs. Okay, and how do we check whether the treatment plan which we have done is correct or not? Through the prototype restorations, or in other words, temporization. Okay, or mock-ups. So this in vivo testing is done in the patient's mouth, and we will check functionally, phonetically, and we should anticipate that how the final outcome, how the final contours would be. And for that, if we leave this prototype restorations in the patient mouth for 48 hours to check, to test these, whether the envelope of motion is right or not, whether phonetically patient is able to speak right or not, and what is the visibility of the tooth while speaking. We can check all these factors through our prototype restorations. Okay. So once we are confirmed through the prototype restorations that everything is all right, then we can check in the patient in the rest position, in the pose smile position, that how much, what is the visibility of the teeth which is there. We should, in the e-smile, we should see whether we are able to see 50 to 70% of the teeth between the upper and lower teeth. With the F sound, we can see where the teeth are positioned, where the incisors are positioned when the patient is speaking F. This F position is not for checking the length of the tooth, but definitely checking the position of the incisors while speaking the word F. So once the final adjustment are taken and the patient and doctor give approve to these prototype restorations, then these set of provisionals are sent to the labs, and again the lab is asked to go for the definitive restorations. These labs give two key indices to the clinician to check when the final restorations come to the clinicians. So these this is how the incisal index and the aesthetic incisal edge position index is being made in the lab and being sent to the dentist to check for the definitive restorations, to check the incisal edge positions. So friends, as till now here you have seen that all these factors, all these micro analysis, all these macro analysis, all these smile lines, all these horizontal lines, all these vertical lines which we have studied, all these have to be taken into considerations when we go for analog or the manual type of a smile design. So there are many factors which has to be kept in mind, which make this procedure very difficult. But thanks to digital smile design, so by digital smile design, I am not specifically talking about DSD, but I am talking about all the softwares which are available to recreate the smile digitally. Okay, so what are the advantages of all these digital smile design softwares? That they are permutation and combination of all the factors which we have studied so far, and it studies from all the photos, different photos being taken, different videos being taken from the patients for the accurate aesthetic analysis. There is a very good communication between the interdisciplinary team, between the prosthodontist and the restorative dentist and the periodontist and the lab. So there is a very proper communication between each of the team. And after each phase of the treatment, we can have the feedback from the team as well as from the patient. And so this digital smile design software usually allow a re-evaluation in every phase of the treatment. So there is a dynamic and effective treatment planning presentation which can happen to the patient, through which the patient can appreciate a better understanding and a combined multiple factors which can understand what are the multiple factors which are responsible for their oral facial issues. These digital smile design software can be a very important education tool for the patient as it adds to the visual elements into the slide. And we can very well educate the patient that why and how the treatment will go forward. So right now, here I have included 13 smile design software names here. But believe me, friends, nowadays all the labs are having their own smile design software. So it is very difficult to decide which smile design software to go with and which smile design software we should use in our day-to-day practice. To name with the few of the important smile design softwares, Photoshop, I don't think that I need to introduce this to all. Then there is with SARIC, you come with the SARIC SW 4.2 smile design system, the most vastly available smile design software, which is applicable and available throughout the world, is now Exocad smile design software. Because this Exocad smile design software not only includes the in the for smile designing purposes, but for all the other dental and digital workflow, this smile design Exocad software is being used. So through the Exocad, this smile design software is becoming more and more popular. Even the Plan Maker Romexis is one of the very famous smile design software, which usually is included with the Plan Maker CBCT and the smile design setup. Then, of course, the word DSD being famous by none other than the DSD app by Christian Coachman. So this is not the right time, not the right place, or neither I am the right person to talk about the DSD in detail. And then recently, 5 to 6 years back, there is a Smilist aesthetic design software, which is available throughout the world. And so as you can see, I have only included 13, but believe me, friends, there might be 26 or 50 smile design softwares which might be floating in the market. And what to believe and which software to believe, it all depends on your personal experiences or R&Ds which have been taken by the individual software companies. So the older the software company, the more better results you can expect from them. Basically, not only in DSD, but in all the digital smile design softwares, what you come across are these factors. Firstly, the cross. You take a photo usually, and this photo is being subjected to a cross which passes through a midline and an interpupillary line. Then the most important thing is a digital face bow. So this digital face bow usually in maximum of the software passes through the incisal edges. Okay, through the incisal edge, and which is one of the important reference line which gives us an idea whether there is a canting in the occlusal plane or not. Then there is a smile analysis. So there are templates of a smile analysis which can be used for each individual cases. Then there are smile simulations which are available through which we can alter the incisal edge position the canting, the shifting, the tooth proportion, and the soft tissue architecture through these smile simulations in these softwares. Then usually, sorry, usually in the digital smile design softwares, these three lines, the line one, which goes from the cusp tip of one canine to the cusp tip of the another canine. Okay, this one line, then second line in which the middle of the one central incisor to the middle line of the third, second adjacent central incisor, and the third is the midline. Okay, this is midline. Okay, when all these three lines are seen together, we can draw references that that the line one guides the size and the canting, the line two guides the incisal edge position, and the line three guides the midline position of the mouth. These lines are subjected to the digital ruler. So through the digital ruler, which is usually calibrated through the actual length of the central incisors in the or directly from the patient's mouth or from the models which we have taken, and further calculations are done. So here you can see different outlines can be subjected to the photographs, and you can see different measurements can be done on the photograph through these digital rulers. But the important thing, friends, is these digital design softwares are not merely the morphing softwares. Okay, so there has to be an application through which these changes which we are seeing in this digital design software should be implemented in the lab as well. So the best design softwares are the digital smile softwares are those who have worked upon very well to be accepted and accurately transferred to the lab, these suggestions which are given through this digital smile design software. So through this design software, we can go through the white and pink aesthetics, then go through the digital ruler, and from the transferring the cross from the digital to the model, and thus we can achieve the what we have achieved digitally to the model. So I might conclude in the end that aesthetics in purest sense is subjective and is subjected to the artistic interpretation. Okay, so four-way we can see the each and every case visually through the functional aesthetic analysis, virtually through the diagnostic wax-up. We can check it through the prototypes, and through the definitive restorations, we can actually achieve what we have designed in the digital smile design software. So nowadays, dentistry is not merely need-based dentistry, but it has changed to an elective dentistry, where patient asks you to achieve, to get certain type of results from their dentist. And in the recent advantage, the techniques such as digital smile designing is now a very extremely useful tool for patient motivation, and as well as for the interdisciplinary as well as the laboratory communication. So I might conclude my presentation with saying that a smile is nothing but is the light in the window of your soul, and it is each dentist's ability to judge that smile and create that smile for each individual patient. Friend, this is my contact details. Thank you.
Sir, could you tell about protrusion? Like, what would be the exact concluding protrusion? Like, once the final smile designing has been done, like the anterior protrusion.
Yes. So as I have shown you many cases, certain protrusion, certain type of protrusion can be corrected through the orthodontic means. and certain type of protrusion can be corrected to orthognathic ways, and certain type of protrusion can be corrected through the restorative ways. So definitely it is not a simple work. It has go through the interdisciplinary approach, and all the team has to sit together to achieve, like I told you, that your incisor latch should fall within the wet line of the lip when seen from upward. So that is the right kind of smile which we need, or the protrusion which we need in each and every cases.
Thank you, Dr. Vivek, for the insightful lecture. So I would like to ask our moderator, Dr. Mohan, to ask any questions, if any questions have been posted in the chat box. And since I think we have crossed our time, we'll take one or two questions and then we'll conclude the session. So Dr. Mohan, over to you.
Thank you, sir. It's an excellent presentation and very informative on digital smile designs. So we have got two questions for you.
Yeah.
So one is, can you please name few good dental this digital smile design softwares? Already, I think.
I think it's already been explained, but still, yes.
I have put a disclaimer also. I am not representing any of the companies, smile design software companies, though I have worked with few myself. And what from my experience and from the what R&D which the companies have gone through, I would say that the DSD software and rather DSD app and ExoCAD is one of the two famous smile design softwares which are in vogue and which are running throughout India and internationally as well.
Okay, sir. Sir, there is one more question. Can you please explain a little bit on buccal corridor space?
Yeah. So as I have shown you in my presentation, that buccal corridor is a black triangular space which is present while smiling between the buccal surface of the teeth and the inner surface of the cheek. So basically, a smile is a combination of white aesthetic, pink aesthetic, and the black aesthetic. So there has to be a proper proportion of all these three components, the white, the pink, and the black aesthetics, which has to be present in each and every cases. As I have shown in my presentation, where the black zone is much more enhanced, we have to certainly look towards the maxillary constriction which might have taken place. So it can be corrected by two ways, whether it can be done by expansion of the maxillary arch, or we can add the restorative materials buccally to reduce that buccal corridor to make it uniform.
Okay, sir. Thank you, sir. And one more question. They asked for any reference for functional matrix theory.
Yes, functional matrix theory is very well explained. Basically, this functional matrix theory, just a moment. The functional matrix theory usually comes through the TMJ and very well explained by the Okeson in his smile design textbook. And this has been taken directly from the functional matrix theory from there only, where he has started with how to start any of the aesthetic case with first checking whether the TMJ is in proper function or not, and from there how to apply the aesthetic principles to ensure the final aesthetic outcome would be the one which we have decided for.
So thank you so much. I think there's one last question. I think there's one more last question, and we'll end with the question and answer session, because our speaker has one more program to attend. So
Yes,
we'll wind up soon. One last question.
Sir, there is one question from me, sir, from my side.
Yeah.
We have some papillary insufficiency, like black triangles. So, to which extent we can leave
Sir,
this papillary insufficiency?
Sir, regarding that, you would be better person as a periodontist to throw a light on, because definitely, as I told you, this is a interdisciplinary approach, and all the fields are equally involved. So, I think that you would be a better person to throw a light on this papillary insufficiency and how then these black triangles can be corrected. I think so. You can throw a better light than me on this.
Yes, sir. Different surgical procedures and non-surgical procedures are there, sir. To overcome that, my thing is just only if it is class 1,
Yeah,
class 1 according to the Norland classification of
yeah,
papillary loss. So that is that can we go through smile designing with class 1?
yeah, yeah, we can.
So
Okay, sir.
thank you so much, all of you. Dr. Mohan, thank you so much for your time. Special thanks to our speaker, because we were supposed to have this 1 week back, but he was having laryngitis, couldn't speak, but he agreed to come back after a week. So thank you so much, Dr. Vivek, for your presence here.
Thank you
We
very much.
really appreciate, the ISPRP team really appreciates your presence here. And
Thank you very
thanks
much.
to our moderator, Dr. Mohan, for sparing his time and chairing this session. And I would like to thank all the participants. We have hit around 100 participants today, and there are few participants who are watching it through YouTube live. So
Thank
the
you, Dr.
advantage of
Manan.
being an ISPRP member is you have access through YouTube. All the video links are there in YouTube for some time, so you can access it. So thank you so much to our very own EC member, Dr. Balendra. And as he has already spoken to you, we have our essay competition coming up. So the details are there in the ISPRP website. I kindly request everyone from UGs to faculty to private practitioners to send their essays, because this is a annual event, and awards will be announced, and you will be getting a discounted rate for our upcoming annual conference, which will be held in mostly in Delhi. So the details of which we will be sharing in the next coming few weeks. We'll be sharing the details of our annual conference as well. So thank you, everyone. Before I close the Zoom link, I just want to tell you, if you want the certificate, the participation certificate, you have to fill up the feedback form, and the participation certificate will be automatically emailed to you. So just try emailing, just try filling in the feedback, and you will be getting your participation certificate. If there are any issues with regard to your filling the feedback, because a couple of people over the past few months have been having this issue of not getting the certificate, you can WhatsApp it, or you can even email it to me. I will try what can be done. So yeah, so that's it. So until next time, so we have few more presentation. I mean, we have the next month's programs, upcoming events. These are for the month of February. This presentation, what we just heard from Dr. Vivek, was actually the first of the Jan 2024 presentation webinar. So this month's webinar, we have something on bone grafting, and then afterwards we have something on conscious sedation. So these are our upcoming webinars. So please tune in for our upcoming webinars, and preferable be a part of ISPRP. So thank you so much. Thanks.
Thank you. Thank you.
And
Thanks a lot
have
to
a
all.
nice weekend. Thank you so much.
Yeah. Thank you. Thank you, Anand.
Bye.
Bye.
Bye bye.
today is the last day I meet. ஃப்ரீ சோல் ப்ரோட்டீன் எப்படி அந்த மாதிரி ஏதாச்சும் ஒன்று அவ வச்சிருக்க மாதிரி பட்டு இல்லாம